funny story. I was supposed to talk on venous abnormalities, or vascular abnormalities last week, and I just plumb forgot about it. And then I was like, oh my gosh, where's, I don't think I saw that PowerPoint in there. I could not for the life of me find it. And I'm like, am I losing my mind? I know I did this. And then I was reviewing this morning over Acanthosis Nigricans, and it's at the very tail end of that. So we'll talk about, throw that in there today too. Okay, so Acanthosis Nigricans. You will need to know this. This is a skin condition that is linked to insulin resistance and the potential for diabetes. All right. So whenever you see this, you are always going to ask about diabetes or family history of diabetes and educate this person that, well, this is something that's linked with that, so you need to watch this, be monitored for this, because you may develop it. See it more in African American, Latino, and Native American populations versus the Caucasian. Now, very rarely can this be a marker of some type of an internal malignancy, primarily GI tract. This is not going to be your run-of-the-mill Acanthosis nigricans. This is going to be a real rapid onset, a very florid presentation, and in somebody who doesn't really fit the picture. Normally, these people are obese. And again, one of the markers is insulin resistance and increased insulin levels. So they have a hyperinsulinemia oftentimes, but they're not, maybe not diabetic, but maybe pre-diabetic. So you have to know that. You don't really have to know about the pathophys of that. Now there are a few medications that can induce this type of a looking rash. Your steroids, niacin, estrogen, human growth hormone. So you have to ask about those medications too. So what does it look like? The good textbook description of it is symmetric, hyperpigmented, velvety, 2 papillomatous hyperkeratotic plaques. Okay, let's break that down. Symmetric, it's going to be on both sides. Hyperpigmented, it's going to be darker than their normal skin. It could look real soft and velvety, or it can look papillomatous, look real warty and bumpy. Hyperkeratotic, it's going to be thicker. Okay, all that makes sense when you break it down. This really likes the back of the neck, the flexural surfaces, especially the armpits and the axilla. And sometimes you can have superimposed acrocordons, or that's the fancy word for skin tags. Skin tags, having lots and lots of skin tags, is also associated with kind of a pre-diabetic or diabetic predisposition, the insulin resistance. Now, sometimes that's hereditary too, but when you, some people just make them by the thousands, and that's usually, we all make a few skin tags. Now, sometimes when it's pretty severe, I have seen it like on the back of the knuckles, the elbows, the knees, places like that too. But the primary places that you're first going to see it is the back of the neck and armpits and other axillary, or excuse me, body folds. And that's what it's going to look like. That's on the back of the neck. These people will say, my neck is so dark, it looks dirty, and I keep scrubbing it, and it does not go away. That's textbook of what they're going to describe to you. Here it is in the armpits with 1,000 skin tags or acrocordons. But you can see that looks darker than normal. That one looks a little more velvety, where this back one, well, that one looks a little bit more papillomatous. And it looks thicker than the rest of the, it obviously looks thicker than the rest of the skin. Almost looks callousy, a softer callus. All right, so the number one thing is you need to determine if they have high insulin levels or insulin resistance. And you can check for an insulin level. I have done that before. And this is associated with that metabolic syndrome. Surely you guys have talked about the metabolic syndrome. Yeah. You know, there are a few topical treatments. I would say I have probably tried the topical retinoids like we use for acne. Again, to get a sloughing action going, break the skin cells down, but they're probably not real effective. If you can get them to lose weight, if they have hyperinsulinemia, you can treat with metformin, and it can help the rash or the acanthosis. Okay, any questions about acanthosis? This will take us 5 minutes. So. Okay, we've already talked about telangiectasia. These are persistent little dilatations of small capillaries. They're just a little fine line or net-like pattern. They'll blanch. Hello, I've got those on my legs I can show you. Not too bad. A lot of that is genetic in the legs. Cherry angioma. Again, telangiectasia, what did we talk about last week where you tend to see telangiectasia? Rosacea. Sun damage, you see a lot of telangiectatic changes as well. The chest, the lower half of the face. But usually it will spare right here, because that's where the chin shadow is. So you'll see people where they have the, you know, darker reddish brown discoloration here and here, and then they don't have it right there from the chin. All right, so cherry angioma, these are very common. Tend to have a lot of genetic predisposition. These are bright red to violaceous. Violaceous is that purple discoloration. They tend to be domed, or they can be more flat. They tend to be pretty small, about 3 millimeters or smaller, but I've seen them bigger than that. Principally on the trunk, but they can be on the extremities as well. We tend to get these more with age. They can start around age 30, and again, depending upon your genetics, you may be predisposed to making tons of them or very few. I think I just have one right now, so my parents don't have a bunch of those. So again, dilated capillaries in the dermis. These are harmless. People just don't like the looks of them and want to get rid of them. There's a couple of ways. You cannot freeze these off. It's not going to touch it by freezing them. You can take the little electrocautery and first anesthetize it and then just zap it, and that just coagulates that little vessel. Works beautifully. Or you can send them to laser, and they may need to do a couple of little zaps at 2 or 3 intervals to get that going. Yeah.
So when they're more of a dome shape, do they bleed easier, like if bumped?
Yes.
Okay.
If you shave over these, they bleed like stuck. They bleed like a stuck pig. Yes, they will bleed. And that's what they look like. There you've got a telangiectasia behind it, and then those others are cherry angiomas. Completely benign. And our last thing we're going to talk about is a spider angioma. This, again, is very common. This, you have a central arteriole with these little telangiectatic vessels coming out from it, so it looks like a little spider. They will blanch, so you can make it completely disappear by putting pressure on it. You lift your finger up and it fills right back up. Now, one thing to know about this is this can be associated, if you see them come up kind of suddenly, especially widespread, there are some things, hyperestrogen states such as pregnancy or birth control, and hepatocellular disease. Liver disease, you may, if you see somebody that says, oh my gosh, I got these red bumps all over me all of a sudden, you might want to ask about liver disease or check some blood work. Now, the other thing in kiddos, You see them on the face quite a bit, and I probably, moms can be pretty hyperreactive about anything on the face of their child, and they're ready to get rid of it yesterday. But the good thing is oftentimes on kiddos, these may resolve on their own. So I would say, let's give it a year before we do anything. And a young person I have, with a tiny little needle adapter, put electric cautery on it, and it resolved it beautifully. And that's what they look like. I forgot there is one more thing. A venous leg, sorry. Get you all excited and then pop your bubble. Okay, venous leg. This again is very, very common. This is associated with sun exposure. Dark blue to dark purple color. A soft papule. This is a dilated venule. Again, it's common, but you're going to see it in the older population and sun-damaged areas. The most common is going to be your lower lip and the ears. Because of the color, they can look almost black-like until you get up kind of close and you can see, oh no, that's actually more of a purplish color, violaceous color. So it can be confused for something much more serious. One thing that you can do, which I think is important, is to use a glass slide. There is one on the lower lip. See how when you push that glass slide against it and it pushes all the blood out of there, you raise it up and it fills right back up. Your melanocytic mole or melanoma is not going to blanch like that. So this is what they will do. We'll see these on the lower lips and the ears all the time. Again, treatment. Again, you don't have to treat them because they're completely harmless, but you can do electrocautery, just cauterize that vessel, laser, surgical incision. Bam, we're done. Anything else? Questions? All right, go get some rest. See you tomorrow morning.